Hi, thank you. Good evening and welcome. And thank you for making it out in this horrible weather. I was told that Harvard only closes for acts of God. And so this was not an act of God. And so welcome and thank you for coming to this evening's event. We have two of our speakers from Washington joining us by Skype. They tried valiantly to make it down to Washington, but high winds in Washington prevented them from leaving. So they're going to join us by Skype, and we'll try to keep this super interactive. For those of you who don't know me, my name is Amitabh Chandra. I'm a professor here at the Kennedy School and also area chair for social and urban policy, and I direct the health policy research program here at the Kennedy School. Let me tell you a little bit about this evening's event. It's about alternatives to the Affordable Care Act. So we're going to think hard about what's in the ACA, what's working in the ACA, and ways in which we might change what's in the ACA. That's what the event's about. And it comes at a very good time. Just a couple of weeks ago, President Trump and congressional leaders were suggesting that we would have repeal legislation ready to go at the moment that the president was inaugurated. That hasn't turned out to work out exactly as we were told. And the president very recently suggested that we might be waiting till 2018 for some of the repeal legislation. And there's people like Lamar Alexander who feel like we may have to wait even longer. So we're going to try to make sense of all of that today. So let me tell you about who's going to be joining us this evening. Gail Wilensky, who's an economist and a senior fellow at Project Hope, which is an international health foundation, will be a member of this panel. She directed the Medicare and Medicaid programs under President George H.W. Bush. She was the first chair of MedPAC. She's on the board of directors of the Geisinger Foundation, United Health, Quest Diagnostics, and BrainScope, and she's an elected member of the National Academy of Medicine. Also joining us this evening from Washington is Avik Roy. Avik is a doctor and the president of the Foundation for Research on Equal Opportunity, which is a very new and very exciting nonpartisan nonprofit think tank that conducts research on expanding opportunity to those who least have it. Many of you know him as the opinion editor from Forbes, where he writes on politics and policy. He's advised 3 presidential candidates on policy, including Senator Rubio, Governor Perry, and Governor Romney, and his work has been praised from both sides of the political aisle. So New York Times columnist and fellow economist Paul Krugman describes him as a man of personal and moral courage. So you'll hear a lot from Avik today. And then this evening I have sitting all the way over to my left John Gruber, who's the Ford professor of economics at MIT. So right down the street from us. He's the director of the healthcare program at the National Bureau of Economic Research. He's also an elected member of the National Academy of Medicine, the American Academy of Arts and Sciences, and the National Academy of Social Insurance. Interesting for today's debate, he's widely credited to be the architect of Massachusetts healthcare reform back under Governor Romney in 2006, and was an inaugural member of the Health Connector. And so we'll hear a lot from John on sort of parallels between what we did in Massachusetts and what's in the ACA. And then finally, to my left is Kate Baicker. Kate is a professor here at the Kennedy School and also at the School of Public Health. She's also an elected member of the National Academy of Medicine. She serves as the chair of the Massachusetts Group Health Insurance Commission. They've been doing some really innovative work on offering novel insurance schemes to people who are covered by the state. She serves on the board of Eli Lilly. She's also on the CBO's panel of health advisors. And between 2005 and 2000 Senate, she was a Senate-confirmed member of President Bush's Council of Economic Advisors. And many of you will recognize this time period as being the time when we passed Medicare Part D. So we've got a lot of expertise on this panel. So Kate, you're smiling.
You haven't said anything upsetting.
I got this off of Twitter. I have a health policy Valentine for you. Is that a Medicaid expansion, or are you just happy to see me? You guys are supposed to laugh.
Or groan, either one's fine.
Okay, so at the heart of the ACA, at the heart of it, the biggest part of the insurance expansion is the Medicaid piece, right? So approximately 20 million people. And going into the ACA, we really didn't know exactly what Medicaid would do. And you did some amazing work on that. So before we start to think about alternatives to Medicaid, let's try to understand what is the value of Medicaid. What did you do? What did you find?
Thanks for bringing that up. I've done a lot of primary research as well as examined all the research that's out there on Medicaid expansion. I think we have a much better picture of what expanding Medicaid can do and can't do to improve the value of healthcare spending and the health of people it covers. Along with Amy Finkelstein at MIT and a wide cast of characters, including John Gruber, we looked at an opportunity in Oregon to evaluate the effects of expanding Medicaid that was enabled by this bizarre policy situation. I want to emphasize that bizarre point. Policy situation where they had a waiting list for their Medicaid expansion program, and they drew names from the waiting list by lottery. And this wasn't because they thought, science. It's because they had a limited number of spots, and they wanted to allocate them in a way that was fair, and this was the most fair way to do it. So they drew straws from a waiting list of uninsured low-income adults, and the people whose names were drawn got access to the Medicaid program, and the people whose names weren't didn't. And this, to an academically inclined type, suggests a randomized controlled trial. You actually have a control group, and you can say, what did expanding Medicaid do, and what didn't it do? And we found a pretty mixed bag there, which I think was surprising to a lot of people. Expanding Medicaid costs money because people use more health care. And that's probably a really good thing. The uninsured people are probably using too little health care before. But when you expand Medicaid, they go to the doctor more, they go to the hospital more, and they go to the emergency department more, which I think was surprising to a lot of people, but they went to the emergency department about 40% more than their uninsured counterparts. But then there were benefits associated with expanding Medicaid. They had much improved financial circumstances, and an insurance program is supposed to protect you from debt, protect you from getting evicted from your apartment because you have a hospital bill to pay instead of your rent. So their financial circumstances were much improved. Rates of depression dropped substantially. They reported much better health, much better access to care, but we didn't find any improvements in chronic diseases like high blood pressure, high cholesterol, diabetic blood sugar control. We just didn't see any changes in that. We didn't see any improvements in participation in the labor force or income. So that's kind of a mixed bag, and I think it paints a pretty stark picture for policymakers. Expanding Medicaid is really beneficial to people who get that insurance. And there's lots of other evidence beyond the study I just talked about, but it's my study, so I get to lead with it. But also, there are substantial costs. You cannot expect to save money in the healthcare system by expanding Medicaid. It costs money because people use more care, so you've got to find a way to finance it. And that makes policymakers have to evaluate how much they care about the benefits to the newly insured versus the cost of expanding that insurance. And that cost comes in the form of less money to spend on other public policy priorities like education or transportation, or higher taxes for people who have to pay for the benefits but are then not likely to actually participate in the benefits. And that brings politics back into it, and economists are not so good at politics.
No, we're absolutely terrible at it, which is why we're not going to ask the next question to an economist. We'll switch to Avik, who's a doctor, who's quite willing to wade into politics. So Avik, you are intimately familiar with the research on Medicaid, but Medicaid reform is going to be difficult, right? I mean, something like 16 of these expansion states have a Republican governor. So this sort of repealing Medicaid or changing it will be difficult. Your organization, the one that you've just set up recently, your foundation, spends a lot of time thinking about the well-being of the poor, and Medicaid is mostly about the poor. It's a means-tested program. So help us understand the alternatives where you can kind of keep a lot of these benefits, but maybe restructure the program differently.
Right. So first of all, let me just say it's great to be here. Not only is it an honor to always, anytime, participate in a JFK Junior Forum, even if remotely, but this is actually the second one I've done this academic year. So a double honor for me. I'm sorry I can't be there in person to be with you. I wrote a book, Amitabh, a few years ago called How Medicaid Fails the Poor. And the point of the book was not to say we shouldn't try to offer health coverage and access to health care for the poor. It's that the Medicaid program and the specific ways in which the Medicaid program was designed in 1965 and the specific ways in which states and the federal government have tried to wrestle with the cost of the program have made it a program that very poorly serves the people it's intended to serve. So Kate earlier mentioned how Oregon had this quote-unquote bizarre approach to expanding Medicaid, where they basically expanded it to a certain population. They ran out of money to do so, and so they said, well, we're going to expand Medicaid to some people but not others using a lottery. Well, that was unusual, but it wasn't unusual that the state was wrestling with cost overruns in Medicaid. What was unusual is the way they did it. Most states wrestle with their costs in Medicaid a different way. They pay doctors and hospitals less than private insurers and Medicare to provide the same services. And we can debate whose prices and whose rates are the right ones, but the simple fact is that relative difference is very, very important. And what's ended up happening is a lot of doctors have decided that if they have the choice between treating patients who are on private insurance or Medicare or Medicaid, they'll always take the privately insured patients because they're paid more to cover those patients. Then they'll take the Medicare patients if they've got any room left, and then they'll take the Medicaid patients last. And so you have this card that says you have Medicaid, but you don't actually have the kind of access to health coverage that those same dollars, the very same dollars, if delivered in a different way for health insurance and health care, could provide better services to those individuals. And so again, the debate about Medicaid reform in the country today, and related to this event as well, is not so much whether we should cover this population, it's how we should cover this population. And the argument that we put forth at the Foundation for Research on Equal Opportunity, our plan is, as you know, Amitabh, is called Transcending Obamacare. It's something that has circulated as part of this debate in Republican circles, is to say, look, let's take the money that we're spending through the Medicaid program and actually try our best to deliver that money as much as possible directly to patients, to choose the health insurance that serves their needs and to choose the health care that serves their needs. And that sometimes might mean having a component of that subsidy be served with insurance products, but some of it might be through health savings accounts and other things that those subsidies could then fund that don't need to be specifically insured products. And in that way, you can actually not only give lower income individuals, vulnerable population, the opportunity to choose the care that really meets their needs and the coverage that meets their needs, but you create an enormous stimulus for innovation in the delivery of health care to lower income people as entrepreneurs try to figure out what's the most cost-effective way to deliver the services that lower income people actually are telling us that they need, as opposed to a bunch of us sitting in a room deciding what they should have.
So Avik, just to follow up on that, where do you come down with your proposal on this idea of Medicaid block grants? Like, it seems like block grants are they central to your proposal because we want to give the money through block grants to the states and then the states can elect into your proposal where, some states choose to run Medicaid the way it's currently running, others choose to, move to a more market-oriented system where people pick the plan they want?
Yeah, so in Transcending Obamacare, the way we approach Medicaid is a two-step process, or maybe a three-step process. The first step is to take the ACA exchanges, John Gruber's exchanges, and reform them in ways that address some of the adverse selection, make the plans more accessible and more affordable for younger and healthier people who are currently priced out of the market. Once you've reformed the individual market so that it's more stabilized and more accessible to more people, then you can actually take the dollars we spend on Medicaid and gradually convert those dollars into tax credits to purchase coverage on the exchanges. If we believe the exchanges are the right way to offer health coverage to people at 139% of the federal poverty line, or even 101% of the federal poverty line in 19 states, perhaps there are also appropriate venues of care for people and coverage for people whose incomes are at 99% of the federal poverty rate or 88% of the federal poverty rate. So our idea is to gradually phase in the utility of those Medicaid dollars to buy exchange-based coverage and do that gradually over time. People would have the ability to remain in the traditional Medicaid program if they really wanted to, but there would be a lot of advantages for patients to actually have tax credits to buy exchange-based coverage. The most important is that for a lot of the people in this population, people whose incomes are around the poverty line, their incomes are volatile from month to month to year from year. 1 month they're above the poverty line, the next month they're below it. And so in the current system, they're having to switch between Medicaid and the exchanges, and that means different provider networks, different physicians, and there's a lot of disruption in the care that these patients receive, which is, again, a big part of the challenge with Medicaid. And so if we're able to actually have a more continuous insurance coverage program for them, where maybe the subsidy phases in and out at different levels based on their income, then there's more stability in their insurance coverage, more stability in the physicians that are caring for them, and therefore, hopefully, better health outcomes over the long term.
Got it. So you spoke a lot about the exchanges, and John, this is a great place to bring you in. I mean, you were the architect of the first exchange, but these exchanges, I don't know, when I look at the exchanges, the thing that jumps out at me is the fact that we seem to need this individual mandate to work. That seems central to getting all these good risks, all these young people into the exchange. That seems like something that's incredibly unpopular. Now, maybe I'm wrong about that, but that's just my sense, is that people don't like that. So if what we hear from Avik is perhaps let's double down on the exchanges, use the exchanges to kind of expand to Medicaid, we've got to make these exchanges work. The mandate, which seems central to making them work, is unpopular. How can we make them work without the mandate?
You know, it's a great question, and I think that what's strikingly to events like this is how much sort of agreement amongst different parties there are on things. I think that if you look at, what one might call cradle to grave exchanges, which is sort of the, Avik's position, if you add in premium support to what he's talking about, I think there's a lot of economists who would support that. I think that the problem is really threefold. Okay, the first problem, to come directly to be critical of what Avik said, is it's all fine and well to say we'll give people a tax credit that buy health insurance, but because of the low doctor payment Avik mentioned, that tax credit can't buy health insurance. So the problem is we're saying we'll give the poor a health savings account, or as I like to say, it's the let them eat health savings account approach. Okay, poor people can't do anything with a health savings account. Okay, if you have $10,000 of income, you can't afford a $3,000, $4,000 deductible. It's irrelevant. So I have no problem at all with the notion of sort of exchanges extending more, but we have to do it in a way that's affordable for people, which none of the current Republican plans address. I haven't read Avik's proposal. It might address that, but none of the current plans do. So affordability is issue one. Mm-hmm. Issue two is adverse selection, which is the problem that if you just set up an exchange, then what will happen is healthy people will stay out, sick people will go in, they'll drive the price up. This is not an abstract concept. We've seen it in practice. Indeed, 7 states in the mid-1990s tried what is in many current Republican proposals, which is say we'll end discrimination in insurance markets, but we won't have the mandate. And every state has destroyed the insurance market. This is not an idle conjecture. So if we want to deal with this, we cannot escape the fundamental mathematics of insurance, which is 80% of the spending is done by 20% of the people. And those 20% of the people cannot afford to cover that 80% of spending. Something has to cross-subsidize the sick. You don't like the mandate? That's cool. How are you going to cross-subsidize the sick? What's your answer for that? Current alternative plans have no answer for that. Have no answer for how you cross-subsidize the sick. That's the question we have to ask as we consider alternatives. We don't have to, let's step away from caring about labels like a mandate for something else. Let's just ask, where's the money coming from? It can come from lots of places. So for example, you could get rid of the mandate and set up a huge reinsurance program for insurers to say we're going to throw a bunch of money at you to cover the sick. That would work. If you set enough money, that could work. But we have to be honest that we're going to do that. We have to be honest that we're going to increase the deficit to do that. So once again, what is the alternative to deal with the adverse selection? And then finally, the issue that we cannot ignore, that is constantly ignored by people who propose cradle-to-grave exchanges, is the fact that people do a terrible job choosing health insurance plans. Terrible. Okay? We've all been through this. It's really hard. Okay? So basically, if you look at, for example, Medicare Part D, okay, which is really sort of the dream exchange product. Okay, Medicare Part D is prescription drugs for the elderly, rolled out in the George W. Bush administration with a big exchange. We have 40 to 60 choices. Okay, 15% of elders chose the lowest cost plan option, and the typical elder left 30% of the money on the table relative to what they could have saved choosing the lowest cost option. It's really hard choosing. So unfettered choice in a market this complicated is not the answer. We have to set up proper insurance architecture, which brings us back to Massachusetts. So in Massachusetts, we started with a plan like the ACA, which was these different tiers of metallic tiers and free choice within them. And people were just totally confused. So after a year, we went to more standardized choices, saying not only the metallic tiers, but there's standard products, which is an anathema to many of the free choice people. It vastly improves satisfaction with the program and vastly improves the quality of choices, measured by an important article by economists studying the quality of choices on the exchange. So I circle back to, I'm not opposed to the idea of let's put more people in exchanges. I think that's a great conversation to have. But let's do it keeping in mind the problem is most of the people who want to have the conversation, not Avik, but most of the people are doing it in a bad faith effort to cut Medicaid. Okay? If we're going to do this, it has to be an effort that addresses affordability. It has to address adverse selection. Let me just say one more point on that, which is the other talking point for Republicans, which Avik mentioned, is let's offer cheaper choices for young people. Well, that's money that comes out of the pool to fund sick people. And that's fine. I'm all for it. But where's the money come from to fund sick people? We have to keep our eye on that ball. And then finally, we have to think about choice architecture. We have to do this in a way which allows people to make these complicated choices in a sensible way.
So let me, thank you for that. Let me ask you a question on ways to get around the adverse selection. So the solution in Massachusetts, the solution in the ACA is we want the individual mandate, right? We want to force you to buy this product. It's going to be binding for all the people who are kind of good risks there in the insurance market. If we don't like the individual mandate, but we also are unwilling to subsidize these healthy people to buy this product that they don't want to buy, one idea that gets kicked around a lot is this idea that we are going to force you to have continuous coverage, and we'll raise the premium on you if there's a break in your coverage. Now that's sounding a lot like a mandate. It's a mandate that you have to have continuous coverage, but it's not exactly like a mandate. How should I be thinking about the individual mandate, the way we have it in Massachusetts and the ACA, versus this other thing which sounds a lot like a mandate?
Okay, so here's the simple fact to keep in mind. There is no alternative to the right of the ACA which does not increase uninsurance. That's a simple fact. It just can't be done unless you want to spend more money. So if you want to spend the same money at the ACA and you want to move to the right, you're going to increase uninsurance. So the question is, what are the mechanisms? So for example, if we replace the mandate with continuous coverage, a couple issues with that. First of all, we already have 28 million people who are uninsured right now who don't get help by that. In a typical year, 13 million people lose employer-sponsored health insurance and spend at least a month uninsured. Those people don't get helped because they've been uninsured for a month. Now you say maybe you allow a month. It's probably, I don't know the number for 2 months. But once again, the point is that could get you part of the way there, but it doesn't get you as far. And so ultimately, look, we don't know what the right answer is about the number of uninsured Americans to cover. That's a debate, we should be having as a society. But we shouldn't be fooling ourselves to say there's an alternative that doesn't cover fewer people than the Affordable Care Act.
Got it. So Gail, I'd love to bring you into this conversation. There's been a lot of talk about exchanges, and as we think about alternatives to the ACA and then related to that, alternatives to the exchanges, here's something that I've always struggled with. Speaker Ryan talks again and again about the idea of premium support for Medicare. So we get richer people in Medicare to pay more for their insurance premium. That sounds a lot like the exchanges in the ACA, where I'd get less of a subsidy the richer I am. So to me, sitting here, it does seem hard to believe that premium support is a really good idea for the over 65, but it might not be a great idea for the under 65, and closely related to that the exchanges may not be a great idea for the under 65. So how should we be thinking about sort of moving towards a system where what we're doing in the under 65 is not radically different than what we're doing in the over 65?
You actually have hit a major irony that for those of us who support the premium support concept for Medicare, it would sound very much like what we have seen for the exchanges, even to the point that you might want to set the subsidy based on the cost of the second lowest plan in the area. That was an idea that's come up. So yes, there is some distinct similarity. It all depends on how regulated the products are and how much you can vary what it is you do in the exchanges. So let me give some flavor to what I mean by that. Right now, in the exchanges, there's much more control about what exactly you have to buy. Avik has mentioned having some more flexibility, and the question of whether or not you actually have to have a mandate. Both of those can be solved if we look to some of the things that we do in Medicare. Medicare has never been accused of having a mandate, and yet what happens in Medicare is you get the year in which you turn 65 or you lose your group insurance, and after that, if you don't choose to buy the voluntary parts, physician and prescription drug coverage, and decide to wait until you really need them, you'll pay a fee for every month you delayed because of the adverse selection you impose when you do decide to come in. Why we couldn't at least have tried that strategy for the under 65 is just a mystery to me. It has not produced the kind of angst and anger that we've seen with the exchanges. And I'd like to go back to a point that was raised about Medicaid. I think we ought to look at Medicaid versus the exchanges as an example where we saw less churn in the Medicaid program than we did in the exchanges for a lot of reasons. And maybe we can combine some of what Avik has said with what we've learned now over the past couple of years, which is let people who are on Medicaid take their subsidy and buy private insurance if that's what they want, and maybe let people who are within the relevant range of, say, 100 to 200% of the poverty line use their subsidies, however we structure them, and buy into the Medicaid program. Medicaid loses a lot on access, but it provides a lot of benefits. Some of us are much more comfortable of saying, let the people who are affected make that choice so they don't have to lose their delivery system when their income changes. Let them move the money based on their income rather than right now we force them to leave the Medicaid program and go into private insurance. So we may find there are actually ways that we can blend some of the ideas we've been hearing about, making use of what we've learned about what doesn't work, which is the kind of churn we've been seeing in the exchanges, both in terms, despite the mandate, of not being able to get very many young people signing up, in part because we're asking them to cross-subsidize the pre-Medicare population. Seems like that's just shooting yourself in the foot. But also because of some of the other issues that have caused instability among insurance players in the exchanges. We need to find a way to try to stabilize those markets. But we can learn from those things that did work. And while it's costed us a lot more money in Medicaid than was anticipated, not just because there are more of the uninsured that came in through that route, but actually on a per person basis. But we have seen much less churn in Medicaid than we've seen in the private exchanges. Maybe we can learn something from that.
Gail, while we have you here and on the screen, let me just switch gears a little bit to something else that the ACA tried. One of the, if I can call it, baby steps that the ACA tried to lead on was to say, look, there's this fundamental trade-off between, we're just insuring more people is going to cost us money. We don't want to raise taxes, but maybe we can make healthcare more efficient. So let's try bundled payments, let's try accountable care organizations, let's create an entity within CMS called CMMI, which will try a number of these payment innovations. As we think about alternatives to the ACA, what are your thoughts on how we're doing with some of these payment reforms that we're trying, with the goal of actually just making healthcare more efficient, so that we don't have to raise those taxes, so that it's actually easier to buy good healthcare for $3,000 or $4,000 or $5,000?
We've seen a lot of demonstrations being tried by CMMI after a relatively slow start. I think it's time to bring the affected parties, bring policy people, bring physicians and hospitals and seniors into a single meeting place and make some decisions about what the next round of payment for traditional Medicare, at least, the private insurers can do as they wish if they don't want to follow suit, and make our decisions about what happens next. The reason I've been writing that and saying that is I think one of the causes for so little impact that most of the demonstrations have reported is that many of those who are not very enthusiastic about change don't believe these are permanent, so they don't change their ways. And also, there's so many going on at the same time that some of the hospitals and even some of the clinicians are involved in multiple pilots and demonstrations, and that just has to make it confusing for everybody. So I applaud that we were trying some things before in Medicare. We just went with our best shot, the relative value scale and DRGs, and rolled it out to the entire population over several years. I think we have learned something, unfortunately, more about what doesn't work than what does work. We need to make a stab at what is better than what we're doing now. It won't be the last time we change things in Medicare.
Got it. So one theme that ran through a lot of your comments was this idea that if you're relying on premium support, people have to choose plans, right? So Avik, you're very interested in the low-income population. So imagine a world where we've got people with Roy Care, and help us understand what is the evidence that these folks can choose plans that are good for them? Like, I mean, you're surrounded by economists, so we're drawn to this utopia that, like, if it's my dollars, I can go out there and shop. And yet there's a lot of work that simply calling patients consumers doesn't make buying healthcare like buying iPads and computers, right? So in this low-income population, is it mostly optimism that you're going with, or is there information, is there data, is there analysis which suggests that people will pick plans wisely?
Sure. So before I answer that specific question, I want to respond, if I might, to John Gruber's friendly fusillade about the inadequacy of alternatives to the ACA. So he mentioned, for example, that, well, a plan that has a $10,000 deductible and a subsidy for $3,000 from an HSA, that won't help poor people afford health coverage. Well, that's true, but it doesn't have to be structured that way. You could have a $6,000 deductible and a $6,000 HSA, or a $5,800 HSA, where the HSA, much like the cost-sharing subsidies in the ACA, covers the vast majority of the out-of-pocket exposure of a low-income enrollee. So the idea that somehow there's no way in which an HSA could work, that's not true. It all depends on the structure. He said, he expressed a lot of certainty about some things that I don't think the certainty is warranted on. He said that, well, these 14 states that have had guaranteed issue and community rating, they all failed, and that's why you absolutely have to have an individual mandate. There's actually another thing that those states, by and large, didn't have, and that is subsidies to purchase health insurance, right? That's really what's driving the enrollment in the AC exchanges. It's not the mandate, it's the fact that there are subsidies to help people afford the premiums that are there. So subsidies are a very important component, arguably far more important than the mandate, given their economic value in driving the choice of people to enroll in individually based insurance plans. So then he said, well, how do you help young people get coverage? Okay, yes, you don't have to have age bands. You can make it cheaper for them, but then you'd have to have risk adjustment or some other mechanism to get older people funded. Yes, you could do that. You could also have means-tested tax credits, in which, as the premium exceeds a certain percentage of someone's income, as the ACA tax credits do, that excess is covered by the tax credit. That doesn't just apply to low-income people. It also applies to people of high actuarial risk, like older people who might otherwise have trouble affording their premiums. So means-tested tax credits are more robust than merely looking at income. They can also look at things like age and health status. He mentioned the point, and you're alluding to this point about, well, there are just too many choices out there. Poor people, they're just going to have a tough time. They're going to be too confused. They're just not educated enough. How are they going to figure this out? Well, if you actually talk to insurance companies, what they'll tell you is that low-income consumers are by far the most sophisticated consumers they have. Why? Because for low-income consumers, every dollar and the value of every dollar really matters. And so every single loophole in the way the exchanges were designed, lower-income consumers figured them out. For example, insurers started to find, and this is something they didn't anticipate, that a lot of people on the exchanges enrolled in plans on the exchanges from January to September, but not October, November, and December. Why? Because according to the rules of the ACA, the insurers have to wait a month before figuring out that they've sort of stopped paying their premiums, and then they have to have a grace period of another 2 months, by which point, oh boy, the year is over. So they basically paid 9 months of premiums to get 12 months of coverage. That's something the insurers didn't even think to complain about when the rules of the exchange were being designed, but low-income people figured out how to optimize their dollars and provide those 12 months of coverage for 9 months of premiums. So that's an example of something where we routinely underestimate the sophistication of people for whom the dollars really matter. And I think we have to have a lot more, there's overwhelming evidence actually that most innovation economically, Clayton Christensen at Harvard has done great work on this, showing how most of the innovation in the economy broadly, and if only we could allow it to be true in healthcare, happen at the low end of the cost spectrum. It's the incumbents that charge high prices and have high cost structures, and it's the innovators who say, you know what, I'm going to figure out how to deliver the same service at a higher quality and lower cost, and that appeals to lower income consumers who end up being more sophisticated than higher income consumers who are much more price insensitive. And again, to the point about Part D, remember that Part D has come in 60% under budget, the first major entitlement program or healthcare program in history to come in under budget at all, let alone to come in 60% under budget. And so the vast majority of choices that all these theoreticians are complaining about haven't seemed to actually provide the empirical results of really bad choices. Actually, what we've seen is the costs have been incredibly low. And finally, make one last point, the most important point of all, which is John said that none of the proposed alternatives to the ACA would potentially cover more people in the ACA. I can tell you that transcending Obamacare was designed from the ground up to cover more people in the ACA. The modeling we've done, now we haven't had our plan scored by the CBO because I'm not a congressman, but the modeling we used, which came from Steve Parenti, a credentialed modeler who advises the CBO at the University of Minnesota, found that our plan would cover 12 million more people in the ACA over an 8-year period. Why is that? Because the plan actually devotes more subsidies to the lower income population and takes them away from higher income populations, particularly for the Medicare program. So there are ways to spend less money than we spend in America and cover more people. The fact is, the United States, pre-ACA, per capita, was spending more on public health spending per capita than all but 2 other countries in the world. We already had way more government spending than we needed to cover everybody in this country. The reasons that we have failed to do so is because we have been subsidizing, in many cases, the wrong people. We've been subsidizing Hillary Clinton.
Let me just interrupt you. Let me get someone else.
And also, it's subsidizing the wrong things. And I'm done.
All right.
That was it.
That's great. Kate, you have spent a lot of time, and when I read what you write in the journals, you spend a lot of time talking about this trade-off that always gets missed in American healthcare. Like, we have this need to say we can insure more people and spend less money, right? I give you the floor. So help us, help. I mean, that seems like, if that's possible, we're off to the races, right? But that is the key issue. Is this possible?
I think a key distinction between what Avik is saying and the the sort of magical thinking of somehow we're going to be able to spend less money and get more people insured, and they're going to have more health care, but it's going to cost less, and they're going to have better health outcomes, and we're going to have better federal budgets. There's a real disconnect.
You mean
there.
I won't get a pony?
Everyone gets a pony, and they're free. The disconnect there is, I think Avik makes a great point that you can redirect money that's being spent from higher income people to lower income people, and that would result in more lower income people being insured. It just takes money to insure people. And then the question is, what happens to the higher income people? Well, they probably don't go uninsured. They probably pay more out of pocket, or more in premiums, or they have less generous plans. When you're taking money away from higher income people, that's redistributive, and that may line up very well with your policy goals of getting more money to sick people, more money to low income people. And if that means that higher income people or healthier people are paying more than they would otherwise, you need incentives, whether they are penalties for not participating in markets or big carrots for participating. I think the difference between the carrot and the stick is really more a matter of philosophy and language than the actual dollar amount. But if you throw enough money at getting people to participate in insurance markets, they will be insured. And the question is, who's bearing that cost? And I don't think we would spend less on healthcare. Who was spending the money would change. You would get more people, higher income people would be paying more for healthcare than they were otherwise, and lower income people would be getting more healthcare than they would otherwise. And again, how you want to structure that redistribution is about your policy priorities, about the opportunity cost of the money, and how much redistribution you're willing to do, acknowledging that it comes with a cost to the economy. Whenever you do redistribution, there's deadweight loss or a cost in economic drag, and that doesn't mean that you don't want to do the redistribution. You just want to do it mindfully. You want to think, how much do I care about the resources at the low end of the income distribution versus the high, and how much of a hit am I willing to take to the total size of the pie to change the distribution of it?
What's key about Avik's point is that it's not, I'm just going to spend less on healthcare and get more people covered. It's that I'm going to do more redistribution. So some people are going to pay more in the form of taxes, and other people are going to get more as a result. We might be spending more on healthcare in total.
And here's yet another place where politics plays into all of this, which is of course everywhere, but the who bears that cost is often far from transparent. When you have a mandate that employers offer insurance, that kind of sounds free, like it doesn't score in some ways, but there's a real cost to it. It changes the way resources are used. And when there are, when workers get health insurance through their jobs, I think if you ask most workers how much their health insurance premiums are, the best they can do is tell you how much they pay. But in fact, they're paying 35% of the total premium. The employer's paying the rest. That doesn't mean it's coming out of some magic secret pocket the employer has. It's coming out of workers' wages because more of their compensation's coming in the form of health care, health insurance. Less of it is coming in the form of wages that they can use for, their rent or their food or their kids' education. So the cost is ultimately borne by the people who get the health insurance, regardless of who writes the check. And that lack of transparency about where money is coming from, how money is being transferred implicitly by the premium structure from richer people to poorer people, from healthier people to sicker people or not, that lack of transparency is, I think, a real barrier to a nuanced dialogue about how much should government be spending on healthcare and who should be paying for it.
Right, opacity is definitely the scoundrel's refuge here. There's no question about that. So we have a bunch of time for Q&A from the audience.